I am Tina Sanders, and I'm the CEO and founder for Fqhcs Family Services, and I want to welcome you all to my home. Phalanx is an ancient word which means a body of people unified by a common goal. People always ask me all the time, what is Phalanx? Where'd the name come from? So I just wanted to start off with letting you know what Phalanx actually is. Nearly 20 years ago, my husband Gladstone and I chose the name Phalanx because of our vision for what the organization could be for the communities we would serve. I am proud to say that legacy has borne out in the 19 years that we've been in operation. Phalanx has grown from an organization of 18 employees, facilitating 5 programs, to almost 70 employees, carrying out over 20 programs for youth, adults, senior citizens, reentry citizens, veterans, and the homeless. In the past 19 years, we have helped over 20,000 individuals gain education and vocational training, job readiness, employment placement, and beyond. We have impacted more through our many weekly, monthly, and annual community events such as our back-to-school extravaganzas, Thanksgiving turkey baskets, holiday coat, and tree giveaways. I am particularly proud of how I and my staff came together to help the city of Chicago and the far south side community confront COVID-19. We simply could not retreat and abandon the community at the time of its greatest need. Instead, we quickly pivoted and made it a priority to maintain as many of our direct service online. We continued case management, conducted our classes, training, mentoring, and outreach on virtual platforms. Excuse me. Now, I'd like to thank you all today for joining us at Phalanx to discuss a topic that has affected Chicago residents deeply and extensively: health equities and the life expectancy gap for particularly the Black and Latinx communities. Our discussion today will show the ways in which the City of Chicago, City Department of Public Health, and the partner organizations from across the city are working to combat the problems through their work on the ground, as well as through programs that are soon to be put in place. Phalanx is one of those organizations. I am extremely grateful that we serve as a Healthy Chicago Equity Zone regional lead, along with our 4 regional lead partners, with the opportunity not only to participate, but to play a leading role in those crucial initiatives. Since June 2021, as part of this initiative, Phalanx, along with its 11 community agencies, have been able to sponsor 267 community events, vaccinating 2,285 people. And COVID, thank you. And I want to say that was not an easy chore to get our community to come out and to be vaccinated. It was like pulling teeth, but we've done it and we're still continuing to get them out. So we're very, very proud of that accomplishment. Through our health initiatives, we have distributed $112,000 in vaccination incentives and over $75,000 in direct cash payments to community and essential workers during the height of the pandemic. On behalf of the agencies and residents of the far south side, I want to express our gratitude to the mayor for our HCEZ program. That program has been a godsend to the far south side. If you could just talk to some of our community agencies, they would tell you that never in their wildest dreams that they think they would be able to bring their community together, have the money to spend to do these events. So they're almost in tears when they talk about this initiative. And I am too, because of the impact that COVID had on our community, and that we were able to combat that with your help. So thank you. One topic off the subject before we get started. Mayor, on behalf of our young people, I want to say thank you. The One Summer Chicago program has been around a long time. our youth made $8 an hour for years. The mayor came in her first year, she raised the salary to $14 an hour. This year, it is $15 an hour. So Mayor, on behalf of all of our youth, thank you. All right, let me see where I go from here. I'm going to introduce our panel, who will talk about our health disparities and life expectancies and also take questions. Von Bryant, he is the Executive Director of Metropolitan Peace Initiative. Chi Oku, okay, I'm sorry. Executive Director, Ever Thrive, Illinois. Brenda Battle, RN, BSN, BMA, Senior Vice President, Community Health Transformation, Urban Health Initiatives. Dr. Melissa Simon, Co-Chair of the Health and Policy Committee, Illinois, UNIDOS. Okay, I knew I wasn't gonna get it right. I apologize. And Dr. Allison Arwadi, who I am going to turn this over to. I think I got that right. Okay, Dr. Arwadi, thank you. Right.
Thanks so much, Tina. And thank you, all of you, for being here today. We're here because today we are formally releasing the 2020 life expectancy data for the city of Chicago. And you might say, wow, it's 2022. Why are we now talking about 2020? But the way data works is that we count COVID cases. We know how many people have died from COVID in a given year. But it takes about a year for all of the death certificates to come through, all of the underlying diseases to get looked at, and there's sort of a formal analysis that happens about a year later. And so today, we are really looking at both the direct and the indirect impacts of COVID on Chicago. And the news is not good. The news is not worse than it is in other cities. There are many cities around the country that have been hit even harder. But what we see is that even before COVID, the Chicago Department of Public Health had made a decision to focus on life expectancy. How long do we expect people to live? Because you cannot fudge that data. When somebody dies, that is the end of the game in terms of that data. And I think it is the strongest indicator of a community's health as well as opportunities. And so even before COVID, there was a major racial life expectancy gap here in the city of Chicago, where Black Chicagoans lived more than 9 years less long than other Chicagoans. And with COVID in the first year of 2020, not only did we see life expectancy drop for all Chicagoans, all races and ethnicities, but we saw that life expectancy gap widen so that now Black Chicagoans on average living about 10 years less long than white Chicagoans, and life expectancy for Black Chicagoans falling below 70 years for the first time in many years. This is not just about COVID. It is not just about healthcare. It's about opportunities, root causes. And in addition to that life expectancy gap, we also saw Latinx Chicagoans get hit really hard with COVID, actually the biggest drop in life expectancy among Latino Chicagoans in that first year. So we see this as sobering data. One of the reasons we're here at Phalanx is that the Healthy Chicago Equity Zone model is the city's attempt to take some of what has been good with COVID, funding community-based organizations working together on things like vaccinating, moving that work forward to continue to fund these networks to work on things like chronic disease. Because even in the year 2020, heart disease was still the #1 thing that killed Chicagoans. COVID was number 2, and it goes on from there. So the folks who are here today really, are critical to us as a city, looking really soberly at where we're not doing as well as we need to do, and all of the ways in which we're making investments to improve that. I encourage you to go to chi.gov/COVID impact if you would like to see a lot of the data underlying the top line that we're sharing today. And thanks so much.
Thank you, Dr. Arwady. I really am taken back to April of 2020. And many of you will remember at that point that the early data that was coming in from the impact of COVID-19 showed that African Americans in our city were dying at 7 times the rate of any other demographic. 7 times. Well, I saw that data a few days before we released it. And we also feared that Latinx Chicago was experiencing a similar kind of impact on the devastation of COVID-19. And recall that back at that time, we didn't know a lot about COVID, but we knew that it was extremely contagious and potentially life-threatening, and that proved to be true. So why I think the data that we're releasing today is so important is to level set with all of us. We have to look ourselves and our city in the eye and deal with the devastating impact of what's transpired from a public health and healthcare perspective over these last 2 years. But also importantly, and that's really, I think, the thrust of the conversation today, is not just to share dire, serious news with you, but to talk about the concrete solutions that are in place as a result of the public health emergency that we've experienced over these last 2 years. And it's fitting that we have a number of different stakeholders at the table for this discussion. Obviously, public health is critically important, but also street outreach and street intervention, because we know that violence continues to play a role in the devastation of life expectancy in Black and brown communities. We also have folks who are researchers and others who come together with us to forge a path forward on a better Chicago and a better future for our residents who are most in need. Teamwork, collaboration, and transparency have to be the hallmarks of the work that we are doing. And looking at really fundamentally what are the root causes of the challenges that we're seeing. And if you haven't seen it, I just want to also talk about some of the data that has come in for 2020. 35% of Black residents lost health care coverage during this time period. 27% of Latinx residents were unable to access health care. And let me just pause there. The answer to a lot of these problems is access to high quality health care. We have to keep that front and center in our efforts, because we can talk all the talk, we can engage with trusted stakeholders in the community, and that's important as well. But if fundamentally people don't have access to high quality, affordable health care without regard to ability to pay, without regard to citizenship status, we are not going to make meaningful progress in the city. So every time someone raises this issue, bring them back to this core solution that has had tremendous impact. When we've expanded Medicaid access, when we have made sure that the Affordable Health Care Act is alive and that people have access to that at various income rates, it makes a meaningful difference. So that's something that we've got to keep emphasizing and frankly demanding from policy makers at all levels of government, the federal government, state, county, and of course local in Chicago. The other thing couple other things that I want to also emphasize. The virus is only the second leading cause of death in Chicago, as Dr. already said, behind heart disease. But those underlying conditions that we've now come to know very well, those exacerbated the risk for residents in our city with this this virus. We know from the recent Omicron surge that people who are unvaccinated and people who had these underlying comorbidities, they were most at risk for serious outcomes, meaning being hospitalized, meaning long COVID, and meaning death. So the work on getting people vaccinated is not over. And particularly when I think about the South Side and the far South Side, we go through this data on a weekly basis, and folks, there is still a lot more work to do. If you look at communities from Inglewood South, and particularly this far South Side, we still have to get the vaccination rates up and over the 50% threshold and keep them there. And the way things look is we are going to need many COVID shots over our lifetime, because COVID is going to be something that we are living with, not unlike the yearly influenza outbreaks. So it's absolutely essential that we break through, that we get people off the fence. Their hesitancy is real, and really at this point it's person-to-person discussions, but we've got to be committed to making sure that we do that, because the progress that we are making in other fronts won't be meaningful, and certainly won't be lasting if people are still subject to this unfortunately deadly virus. So last thing I'll say on this front is this. We do have concrete solutions. We haven't been sitting back and waiting for the data to roll in. Dr. already referenced and Tina referenced our Healthy Chicago Equity Zones. This is the path forward. We have divided the city up into specific zones, working with trusted community partners to really be the leads on all things public health for us in the city. This is the future. The 600 plus individuals that we were able to hire initially to do contact tracing, who then pivoted to be vaccine ambassadors, and now are going out into the private sector to work on healthcare issues. This is the future. The community healthcare workforce that we started to stand up and we are continuing to support, this is the future. Groups like Illinois Unidos, who are speaking and being advocates on behalf of populations that are most at risk. This is what we need all across Chicago, particularly in those most vulnerable communities. This is why we committed $1.9 billion in investments in this year's budget to work on things like affordable housing, to work on things like violence interruption, to work on things like mental health and access to care, and making sure that our young people have an abundance of opportunities across our city. We've got to strengthen the families and meet them where they are. And we are well on our way to doing that. But this is an important and sobering milestone that really measures how far in the journey we are and what we need to do to get to the destination. Let me just say this in closing. Tina, Phalanx has been a tremendous partner for us. I can remember walking in the door probably about 3 years ago for the very first time, and really getting to understand the real challenges and the needs, but also the opportunities of the far South Side. Communities like Roseland and Pullman. We have much work to do to really, I think, combat the generations of disinvestment in the far South Side. But I want you to know, one, I'm grateful for what you do. Thank you again for the CPS spring break work that you did in partnership with so many. But I also want you to know that you have a partner in me. I see this community. I have a deep appreciation for the needs, and I'm fully committed to making sure that we do everything possible, just as we've been doing on the west side, just as we've been doing in other parts of the city. The south side, the far south side, needs us, and we are going to be here. Let me also recognize and thank Representative Slaughter for being here with us today. He's a champion for this community in Springfield, a great partner to me and my team, and I'm grateful, Representative Slaughter, that you've taken time out of your busy schedule to be with us today. So I think with that, we will pivot to our questions. And in the discussion, and then we'll save time at the end for members of the media to also ask questions. Let me start, if I can, with you, Brenda. Sure. First, I want you to talk a little bit about what you do at U of C, and really the commitment I think that U of C has made to address some of these long-standing life expectancy, healthcare gap issues. I don't think people truly appreciate it. You all have been at this work. Your new president, I think, has made a real commitment and partnership. So why don't you tell us a little bit about what you're doing?
Sure. So my role is really to leverage the assets of the broader university and the medical center brings alongside the community in their assets to address broad range health disparities. To the earlier points that were made, the South Side is wrought with morbidity and mortality challenges, particularly around chronic disease management, and we saw the evidence of that with COVID and with the rate of hospitalizations and deaths on the South Side. What the University of Chicago has been doing for many years is working alongside the community to address these longstanding disparities. We developed a collaborative with the federally qualified health centers and the community hospitals on the South Side about 15 years ago to begin addressing these disparities. But most recently, in the last couple years, we created a coalition around how do the healthcare ecosystem on the South Side of Chicago work together in a collective way to really address the disparities that our community are experiencing, particularly in chronic diseases, heart disease, cancer, diabetes, all these things that worsen the impact of COVID for people in our communities. So our work has been really to work alongside the community to determine how do we create health and wellness on the South Side of Chicago? What is needed? And the community told us we need access to care. 56% of people on the South Side leave the South Side for care because they can't get access to specialty care. They spend 60% of their time getting care in emergency departments, and they can't, and there's a few hospitals in the last 25 years, 10 hospitals have closed on the South Side of Chicago. In the last 10 years, hospitals have closed and services have closed. So they said, we need access to care. We need to have a managed chronic disease approach to how we deal with these diseases that all of you healthcare providers are participating in, and that we don't do when we go to a health center for care. We get a different approach to how you're managing my disease than we do when you go to U Chicago Medicine. So make sure that you guys create a care model that ensures that when we get care in the South Side, we're getting consistent, standard, high quality care on the South Side. They also said, we need connectors to care. So thank you to the workforce that you developed. We're hiring 400 of them. We're trying to get every last one of those 600 folks that you put into the workforce and hire them for our Southside Healthy Community Organization. So that we can create advocates for Southsiders, navigators for Southsiders to help improve the coordination of care within the South Side, within the healthcare ecosystem, but also when we're working with community-based organizations and alongside you and the care that you're providing, the service that you're providing, connecting that care to the care that we as healthcare providers are providing. And lastly, the most important component of all of this is that care has to be connected through technology. That we can't care for people in our respective healthcare institutions and not know what's happening in the respective institutions. So we are developing a connected technology system that will allow all of the providers on the South Side to not only deliver the same high quality care, standardized care, but also to connect and know that when care is delivered at U Chicago Medicine, that same level of care is being delivered at St. Bernard and Roseland Hospital and Jackson Park Hospital, South Shore Hospital and Trinity Hospital. This is what we're doing to ensure that Southsiders get high quality care, to your point, get the same level of care regardless of where they're going for care on the South Side. And we're excited about it. And I really do have to thank the Department of Health and Family Services and the governor for funding this project. Honestly, you can't do this. I think somebody mentioned the funding that you provided. You can't do this type of connected work without the right type of funding to support it.
Thank you. Allison, I think two points that I'd like you to kind of lift up as part of this discussion. Number one, tell us a little bit about the importance of FQACs and the work that we did through the pandemic, but also on the ground, and how that's going to be important going forward. And if the second question is, explain for folks that may not be familiar what we're talking about when we say Healthy Chicago Equity Zones, and really kind of what the thought is behind those.
Sure. So first of all, federally qualified health centers, also sometimes called community health centers, are absolutely critical to our health infrastructure here in Chicago. They receive extra funding from the federal government to make sure that they can see anybody, regardless of their immigration status, their insurance status, or their income status, sliding scales down to zero. We are lucky here in Chicago to have 22 networks of these and a couple hundred locations. Some of the school-based health centers, for example, are federally qualified health centers underneath it. Many of the strongest clinical partners across our city are in that network. And so CDPH, really, when we are looking at healthcare access, along with the hospitals, really that federally qualified health center is the front door. It is the primary care. It is often the front door to behavioral health care, mental health care, substance use. There's lots of work to do in coordinating, but one of the things CDPH follows is whether Chicagoans say, I have a primary care provider who knows me and knows my health and can, help take care of that. And FQHCs are critical to that work, and we saw that in COVID in spades. There are some cities that have just a handful of these. We're lucky to have the number that we do, but we need to support and grow them. There's been additional federal funding, but also at the city level, we have worked to put quite a lot of additional funding in, particularly in the behavioral health, the mental health space, to grow that and build that in. So really, really important partners. And the Healthy Chicago Equity Zones. So when we developed Healthy Chicago 2025, every 5 years, to be an accredited health department, you have to do a community health, impact assessment. And that's when we made the decision to focus on the 5 main drivers of the life expectancy gap: chronic disease, infectious diseases, now including COVID, gun-related homicide, opioid overdose, and infant mortality. And so those 5 are the central piece that we are putting additional effort and funding and growth into. But the Healthy Chicago Equity Zones really grew from COVID. This recognition that if we can fund lead organizations, some being healthcare, some being not traditionally healthcare, Phalanx more traditionally employment support and development, but then through those lead organizations, make sure there are smaller community-based organizations in every community working together in the same way that they've worked on vaccine, to work on some of these other issues so that really decisions and even the focus is being driven by community. That's our goal. I think it's one of the more unusual things we've done as a city in response to COVID and what comes after. But Mayor, you've often talked about not building temporary scaffolding. And during COVID, we have tried very hard, as we've made all these investments, to think about what comes next and how do we grow and really work on these issues as a city.
No, that's exactly right. I mean, there could have been a lot of Band-Aid measures that we did through COVID, but we really felt like this gives us an opportunity to look these longstanding, seemingly intractable issues squarely in the eye and build the kind of infrastructure, collaborations that we need going forward. So this has been, I think, a tremendous outgrowth of what was otherwise the crisis of our lifetime. Let me shift to you, Vaughn. Obviously, you represent many of the community-based organizations through which CDPH is working to reduce violence in a coordinated approach. Tell us how you view the work that you are leading with a public health lens.
Yeah, I think the way I view it, at least let me do it in phases. When we got started, we were thinking about convening a coalition of providers, providing standards of practice, making sure people had training, taking away a lot of the administrative burden so that they could really focus on providing that street outreach, providing case management services, having events in the neighborhoods to really execute on the work. I think that now that we have sort of built the trust of our organizations, now the work is how do we take care of our workforce and how do we continue to build our workforce so that the things you guys are talking about in terms of building an infrastructure, we're talking about a civilian infrastructure for public safety in the hardest hit neighborhoods in Chicago. So it's really making sure that we're in the right places, that we fund them with equity based on, severity of crime, and that we build up the people that have to really play the roles. I want to mention one other thing. We talk about it from a health perspective. Part of health is being engaged in society, being engaged in our economy, and being engaged in our communities. We have to build up the people who are going to be our teachers, who are going to be our fire, who are going to be our therapists. Those people live in these communities, and they're the ones that have to play the role. Nobody's going to fly in and do it for us, so we have to really build those people. And I think when they do that, they're going to feel better about themselves, and then they'll engage with healthcare from a empowerment perspective versus the fear of not really wanting to deal with it. So those things are critically important.
So I'm wondering, in your work, and for those of you who don't know, Vaughn is part of Metropolitan Family Services and really leads the work of street outreach and street intervention, and really building up and professionalizing the workers who are out there, many of whom themselves are dealing with their own trauma of longstanding, many of whom who have been criminal injustice involved, but frankly, because of those life experiences, bring a level of credibility to the work with those young souls that we're trying to save from the street. But I guess one question I would ask is, in this context, how much have you had to do with myth busting among the street outreach workforce as well?
You said what busting?
Myth busting. So,
amongst the street outreach workers?
Yeah.
A lot. I mean, I think that one of the things that they struggle with is getting more education or even professionalizing street outreach. When they first came to the Peace Academy, they all came with sort of a hesitance, like what are they trying to do to us? Not understanding that this is something that has transferable skills. You actually are a professional, and we're gonna give you the language to say, when you do this, that means that. And I think it's really given them a level of confidence that has gone a long way and built a community, a professional community amongst people who are really in their first jobs. And even things like, when we talk about access to care, all of our outreach workers have health care, but don't even understand how to access it through their employer. So there's a lot of not only myth building, but education that has to happen in terms of not only learning how to do your job, but how to be a professional, how to take care of yourself, how to take care of your family. So it's a lot, but it's the most rewarding work I've done in my life. So
that's great.
Yeah.
That's great. Let me turn to Chi-Chi and Dr. Simon. Obviously, throughout the pandemic, one of the, I think, big lessons that we learned is hyperlocal is where it's at. That we cannot swoop in from on high with solutions that are not informed by trusted community voices, experienced community voices. I'll give one perfect example. Early on in the pandemic, we were going into Auburn Gresham, and we had a lot of preconceived notions about what that community needed. But when we sat at tables that were already set, the number one issue that percolated to the top in the middle of the pandemic was food insecurity. People were hungry and needed access to food. And sure enough, when we went back and looked at the data, the calls for 311, that was absolutely what was happening in the community. And that was one of those big aha moments for us, which is you can go in, and it's impossible not to have preconceived notions, but you gotta listen to the people on the ground and respond to the lived experience of people in community. So I guess my question for each of you is, what does that hyper-local experience mean to you? And I'll start with you, Gigi.
Yeah, thank you so much. I would say that, that hyper-local community focus is really the core at what we do. Everything that, all of our programs, all of our initiatives are really shaped by what we hear from the community. And so we've been engaged in a couple different areas around birth equity, vaccine education and outreach. And expanding comprehensive, healthcare, advocating for that. And all of that has been really shaped by what we're hearing for the community. One example is we've been partnering with CDPH on the Family Connects pilot, which has been a real honor for us to be a part of launching this, and I think something that is game-changing for our city.
So tell us what that is, so
Yes,
everybody
sorry.
knows.
Yeah, so Family Connects is a universal home visiting program, and so we are in the pilot phase, actually getting ready to expand this, but we're working with several different hospitals within the city, one of them being University of Chicago, and the nurses, right around 3 weeks after someone has given birth, they will contact that person and set up a home visit, and that home visit is really to help provide support for the family. So doing things like baby checks, how is the mom and the parent, how the parent's doing, and also looking at family support. And so our role in that is to convene what we're calling the Community Alignment Board, because we're working in Region D, which is like the south side of the city, so Hyde Park, South Shore, South Chicago, that area. So we bring together community-based organizations and community members, and we convene them on a regular basis, and we get data from CDPH and from the nurses who are doing these visits to understand what are they hearing, what are the needs of the families that they're meeting with, and then how do we work on a very hyper-local level to ensure that those resources are available to them. And so over the last year or 2 years, what we've really heard are our barriers are housing, like those is a huge need. Childcare, which is not surprising given everything that's happened during the pandemic. And another need that's kind of popped up is just awareness of the program and shifting the focus around home visiting from a negative thing to this is actually, we all need support. Every one of us, no matter where we come from, we could all use support, because raising a family should not be a single person's job. It is something that the community has to come around and help to provide. And so we're also trying to change that narrative to say, we're all in this together. Just because someone is coming to visit you doesn't mean something's wrong. We just want to strengthen the family unit and strengthen the supports around you. So we're leading it on the community side and really trying to, on a very local level, meet some of those needs. We partnered last year with an organization called Share Our Spare when we started to hear there were needs around diapers and car seats, and we provided funding that came from CDPH to ensure that we could get those resources directly to the families. And so none of that would come up without this community support and really understanding what are the real true needs, not just what we think they are, but what are the real needs that we're hearing from the community. And so I'm really excited to see this expand in our city, because I think we need more of this, and this is how we really start to strengthen families and ensure that families are able to thrive in a meaningful way.
Can I just add, more than 90% of Chicago families have an unmet need in those first few weeks after a baby is born, where we look at that data. And we've seen infant mortality, remember, one of the biggest gaps there, but it almost doesn't matter where somebody lives in this city. It is a very vulnerable time after, mom and the great aunt and everybody goes home. That is for mental health, for physical health, and for city access. So we are using the American Rescue Plan funding to take this citywide. The idea that every baby born in the city of Chicago, there is a nurse who visits at the hospital and then a home visit a few weeks later. Everybody get that family plugged in, and then use the community-based work. So,
and why this is so important to me personally is if we are trying to make sure that the various touch points in a young person's life, that we are providing that support, that love, that opportunity, it really begins at birth. And so having that nurse go there with really the first kind of intensive case management gives us an opportunity to see where there are gaps, and then connect that family up to resources right there in the community to start that child on the right path from the earliest possible age. So Dr. Simon, I want to come to you, but I'm going to set up the question this way, and the question is about local activity, but I want to say this so people here understand this. Again, let's go back to 2020 and really into early 2021 when we first got the vaccine. What we were seeing throughout Latinx Chicago is surging case rates, lots of hospitalizations, and deaths. And it took us a lot to get that number down. We didn't see the same kind of impact that we did in Black Chicago, but it took a lot more on the ground effort. And Illinois Unidos was really at the forefront of that work. I would say we had healthy tensions in the early days, but I think really formed an incredible collaboration. And I just want to give you the good news story of this. Now, as of this date, and Allison will keep me honest here, if you are in Latinx Chicago, you are more likely to have received a first shot of a vaccine than white Chicago. I mean, it is a tremendous turnaround. And some areas of Latinx Chicago, I'll point out Belmont Cragen on the northwest side, are one of the most heavily vaccinated neighborhoods in our city. And it is in no small measure to the work that Illinois Unidos does. So I think that's a good setup to say, all right, how does hyperlocal work, a focus on hyperlocal activity mean that we can change around the health outcomes for people in those localities?
Super critical. Thank you for that question. Thank you for what you're doing today. It's really important to look under the hood of the car and examine what exactly is in the engine and all those parts and why we have the phenotype that we see right now. So absolutely, Illinois Unidos is not just me. It is a huge collection of the we, and it is the power of that collective we that has brought us to success today. We still have a long way to go, and yes, we do hold your feet to the fire. Sometimes it's a little hotter than others, but it's all
right.
good.
I've got my flame retardant socks on.
That's good. That's good. That's good. But it's really important to do that, to understand that in order to have that hyper-local approach, you have to get everybody across every sector together. Health is in every single thing. This was an infectious disease pandemic, all right, impacting health. But as we see, it impacted everything else. Economics, economic resilience of our communities, employment, insurance, access, every single facet of access, every single facet of social, economic, and political factors that drive health. And without health, you don't have insurance. Without health, you don't have the ability to be in a job, right? You don't have the mental vitality to maintain, right, all of those things, because we all know that we have to multitask. Right? And that was super critical in the Latino response. Things like the approach to vaccines, not having the National Guard in their uniform when you're in our communities, because we aren't going to get a shot when you have somebody in the uniform giving it to us. Right. Understanding all of the different nuances of access and insurance. Of the 10% of Chicagoans that don't have insurance, we represent 50%. And that's substantial, and we are grateful for some of the new legislation coming around, right? We have ways to go for that 18 to 44-year-olds, but again, important. Our workforce, so the community health worker model is from Promotoras de Salud, health promoters from Latin America, all right? That's what we do best, that's what we know, and so that really helps tailor that hyperlocal response. And our community health worker model flourished under Illinois Unidos. We had special partnerships with media and with the politicians and the policymakers, with the Department of Public Health, both at the Illinois state level, the county level, and especially the local Chicago level. So all of those things were really critical in moving the needle forward. But again, what I have to say and highlight is that we had made so many gains, we lost a lot of those gains. And right now, with respect to our economic resilience moving forward, it's going to take a while to recover. 1 out of every 2 people in the Latino community have dropped out of going to higher education. 1 out of every 2, 50%. That's unacceptable. So we got to figure out how do you do that? So now if you don't have higher education, how are you going to lift the whole entire economy and vitality of communities? And those numbers are going to continue to decline if we don't have education. We know that education is a super important driver of health. So all of those things are really critical. Thank you.
So I've got two last questions. The first is for the healthcare providers. Everybody knows someone in their family who says, I don't want to know.
Yep.
And that fear of the unknown keeps people from forming a relationship with a primary care provider. So tell us from your experience, what are you doing to combat that, I don't want to know what I don't know. I'll just, if it happens, then I'll deal with it.
Yeah, this is where the community health worker is so critical, because they don't want to know it from folks in white coats, okay? They don't want to know it from nurses and researchers. They don't want to know it from those folks. And sometimes they don't want to know it from people who are their neighbors in their community that look like them, that might be experiencing the same thing that they're experiencing. But they're more apt to listen to someone who is relatable at that level. And so this workforce of community health workers is so critical to train people who don't have a healthcare background, don't have healthcare experience, but train them in healthcare knowledge, some, but more importantly, that can relate to the people in the community, to talk to them in plain language, in language they understand, about what's happening with them, and to help connect the dots for them. Because that's what I find. I'm a nurse. I was a pediatric nurse many, many years ago, and I took care of families. I took care of kids and their families with them. And what I found is that people didn't connect the dots. And if you don't teach them that this thing leads to that, which may lead to that, and this is why you're seeing this, that's why. And asthma is a perfect example. We have a lot of community health workers that work with asthma. The 6 worst neighborhoods in the city with asthma are right here on the south side. So we got a force of community health workers working on asthma on the south side of Chicago. And they're in homes teaching people not to clean their homes with Clorox. I mean, basic things that help inform people that if you take this step.
All of our mothers told us we needed to do.
Absolutely.
To make sure the house was clean.
So don't clean your house with Clorox. It's rot with all kinds of things that are going to exacerbate your asthma. And so if you help people to just connect those sort of dots, then they're more apt once they get there. You carry them along with someone who can relate to these things with them, you're more apt to get them to those hospital appointments, to those medical appointments, and that's what we've used.
So in addition to that, so I'm an obstetrician, so I help teach people how to catch babies. It's one of the best things on this world. I was doing it last night and yesterday as well. So we in the healthcare system, and I'm also a scientist, a researcher, we've earned the distrust of people, and we have to work even harder to earn it back. And I will tell you, in every single thing we do, I have work with Chicago Public Libraries and the Chicago Department of Public Health to train librarians and to be in safe spaces to deliver messages around health, preventive services, and also the participation in research. And what people's rights are when they participate. Because we need more diverse participation in research so that we know that that research that comes out of it actually applies to the people who bear the brunt of that thing. And the same thing happened in the COVID vaccine, right? If people didn't look like me, why would I want that vaccine if they didn't test it on people like me, right? The other thing is walking with people. Even though I'm in some ivory tower, right, on the downtown, I really think training the next generation of workforce, it's got to be diverse. It's got to be more. We have lots of programs. I lead many of them across Chicago because we have talent across Chicago.
Yes, we do.
Our public schools, any school, we have tons of talent. The problem is the opportunity. So having those pathway programs and opening up more opportunities for more people who look like us to get into the workforce of all types is super critical right now. And that is, that's number one in addition to all this other health, clinical care stuff.
So let me do this because I'm getting that look. Let me ask one last question of the panel, and then we'll throw it open to questions. What gives you hope, Bon?
Honestly, I mean, this is something we were talking about before we got started. I moved to Chicago in 2009. I've worked at CPS. I've worked at the Chicago Park District. Today is the best time for government collaboration. My sort of experience is that within a city department, your department heads are competing against each other versus working together. And I think people are working together now, people are coming together. So whether it's intergovernment, whether it's government with the community, I think, you know, our ability to trust each other and collaborate for the good of our citizens, that's what gives me hope.
I have to agree with that. I was working with David Ansel from Rush and Melissa on the racial equity rapid response work that you led. I've got to tell you, for the first time, healthcare came together with community-based organizations in a way that never happened with the Department of Public Health. Healthcare wasn't working with public health, and now we are all working together in a way that has never happened. This horrible pandemic has created some collaborations that I don't think we ever would have seen. And that's not going to go away. We know we can do it, and we're doing it. And that's where the hope comes. This connected, collective work is why I feel hope.
Dr. Hart, I'm going to save you for last. Oh, here, Chi-Chi, what gives you hope?
Well, I feel like now I'm a broken record, but I agree, because I think the problems that we're seeing cannot be solved by any one group. It has to be across all areas, and we have to come together and figure out how we coordinate care. And I'm so excited to see these opportunities where we're connecting with community members, community-based organizations, healthcare providers, and having the important conversations and not being afraid to name, like, these are some of the root causes of that, which are systemic, things like systemic racism. And I think bringing that into the conversation, once we're not afraid to name that and say that, I think we'll actually be able to start, building these solutions together.
Ditto, and I think in my lifetime, this will be the most important moment for health and healthcare and medicine. Honestly, this moment, because we cannot go back to business as usual. It is not an option, and if it becomes an option, those numbers are going to get worse. We won't reverse that. And that's really sad. And so this is the moment when we harness the power of that collective we, and we hold people's feet to the fire, and we move forward in a way that is innovative, creative, thoughtful, hyper-local, and for everyone.
Dr. Artie, bring us home.
Yeah, I think I'll just, everybody has said it so well, but I'll just say that it is a moment to be in public health. Everybody is thinking about health in different ways, and this is the chance. I could not be more, we were talking a little bit beforehand that we would not have had a conversation like this under prior mayors. We just wouldn't have. And I think seeing the way so many people in this city, so many organizations now see themselves as part of the city's health, and your administration's willingness to kind of put health and invest in that and not in the same old traditional ways and places and partners really gives me major hope for where we go moving forward.
Yeah, that's great.
Thanks a lot, Mayor. Appreciate it. Thanks to the speakers as well. Members of the media, Alejandra and I will bring down the mic. We'll go down the line. 2 questions for reporters. We'll kick it off with Darcel Rocket from the Tribune. Go ahead, Darcel.
I just know that you were talking about the great push that Unidos did for the Latinx population. Have the numbers gotten any better, or because I know the numbers were really lacking for the Black population, even in recent months. So how are we giving that oomph to, getting those numbers up?
Do you mean the COVID numbers, or which numbers?
The vaccination numbers
that
Dr. Simmons was talking about.
Look, I'll start, and then I'll kick it to Dr. Arwady. Look, to be quite blunt, there's not a similar force in Black Chicago like Illinois Unidos. There just isn't. And it's something, frankly, that I've been talking to anybody who will listen in Black Chicago, from community-based organizations, healthcare providers. What I've tried to encourage is get together, and talked a lot about, frankly, the precedent and the model that Illinois Unidos has set that has made, no doubt in my mind, a big difference. Obviously, we have done a lot, I think, also at the city level, but in partnership, and we could not go deep into the communities that have been most impacted by COVID without that trusted partnership. It just wouldn't happen. And it's not for lack of effort in Black Chicago, mind you, but it just hasn't had the same kind of impact that I would love to see, because these numbers are devastating. And they are, as Dr. Simon said, they're not going to get better unless we continue to collaborate and take this moment as the opportunity that it is. And Brenda, I appreciate the comment that you made. You know, a lot of what we heard pre-COVID was the competitiveness of the hospital systems, that everybody was, you know, kind of taking their own approach of, I want to poach patients here, I want to go deep in this community. But COVID forced a reckoning and a conversation across the entire scan of the healthcare system, the hospital systems, the federally qualified healthcare, individual clinicians and providers. It was the emergency that created this sense of urgency and collaboration, and we can't go back. We can't go back. And certainly, as long as I'm mayor, we're not going to go back. We're going to keep going forward with that collaboration, because that is the way in which we reach people and bring them out of these healthcare deserts and isolation that's so critically important. But it has made a difference when we've got trusted community partners on the ground. We launched Healthy Chicago, we launched Protect Chicago Plus in January, February of 2021. And really the truth of the matter is, we said, to heck with the restrictions on who can get it when. We're seeing crises on the ground in communities all across Chicago. Anybody who's eligible, we are going to give them vaccine now. And as a consequence of that, we saw in a lot of areas, whole families, multi-generations coming in and getting vaccinated. That is what really, I think, gave us traction and made the difference. And there's still more work to do. Nobody's taking a victory lap here, but I think it's that concentrated, hyper-local attention and using tables that had already been set, and for us to get out of the way and provide the resources to get the job done, but then holding all of us accountable for the metrics and making a difference in these communities. And it's where it's worked well, it's worked phenomenally well.
Yeah. No, I would just say that, I mean, broadly, if you do look at the data on vaccination in particular, I believe the mayor already said, you know, a Latino Chicagoan is now slightly more likely than a white Chicagoan to have been vaccinated. That is not yet true for Black Chicagoans, but it has been real progress. And during the Omicron wave in particular, it was really sad for me, because we knew that being vaccinated was the most important risk factor there. And so we saw bigger disparities in a lot of ways during that Omicron surge just in December and January, where Black Chicago got hit really, really, really hard. And Latinx Chicago got hit, but not, you know, sort of more commensurate with the vaccination rates that we see. And so, you know, it was a really sad moment for us, because I think in a lot of ways, many of those deaths, not all of them, but many of them were more preventable. And we want to build the kind of trust and connection. It's not all about vaccine that really helps take care of people. And so that when any crisis comes, we don't see it hit our cities so unequally.
And this question's for Chi-Chi here. Talking about infant mortality, this program just recently got started for, you know, the 3-week visits. I guess I'm looking for the metrics on how you're going to kind of track that, as far as like, okay, there's a visit at the 3-week point, but how are you going to like progress it? Is it like every 3 weeks, you know, after that? Or, I mean, that's going to take a lot of, you know, people are having babies left and right. So I'm just trying to figure out the long-term look of this and what it looks like as far as how frequent these visits are going to happen. This is on the back end of obviously the birth, but you know, what's it looking like for a prenatal kind of thing, or does the program just only encompass after or before? I'm just curious about thoughts on that.
And to be clear, this is actually a CDPH initiated program. That's all right. But we've got trusted partners on the ground who are doing the work. Go ahead.
Do you want to answer that?
No, please.
Okay. Well, yeah, so it's really about, yes, so there is a 3-week visit, but it's really about connecting them to broader resources. So it's not just that one visit is important in that, you know, you're catching them at a time where there is a lot of need, but the goal is not that those nurses continue to keep going back to the home, but we really work to connect them to the resources, healthcare providers, you know, mental health like all of those things after that, so that then they are kind of brought into a wider web of support. You know, COVID actually, you know, obviously with everything kind of through our the initial plans of, you know, how we get to people and what we're able to do like in home, but you know, we're continuing to build, working with providers at other hospitals to ensure that people are hearing about this program even before they give birth, during their prenatal visits as well, so that there is more continuity, so that, you know, this isn't a surprise, that they know like, hey, this is coming, this is extra support for me. So again, we are just like in the pilot, again, getting ready to expand this, but the goal really is to, you know, work closely with providers. We have a citywide advisory council with providers on those calls, and we're talking about, you know, how do we continue to strengthen that connection from prenatal visit all the way to the point where, you know, we have a nurse coming into their home.
Yeah,
Yep, go ahead.
yeah, thank you. And I would just add, you know, this is a national model. Every baby born in the state of Oregon, for example, is covered for this, funded for this, and it has been shown to really have significant impact on public health. And so, you know, it's a pretty audacious goal to say we want to set a goal that every baby in the city of Chicago has this, but I think it's the right goal. And so we are in the earlier stages, but we're rolling out to additional birthing hospitals this year, and, you know, using some of the extra federal funding to really get some of this going. But the idea is that when it's not just sort of a let me check in with you for 10 minutes. Like, you should see, you know, nurses are the most trusted professionals in the US, and it is a vulnerable time, but coming in and, you know, having the opportunity to understand who all is in the family, what all are the needs. Do we need to figure out something related to lead abatement? Do we need to figure out something related to food insecurity? Do we need to, is there a 3-year-old or a 12-year-old in the house that might need something connected there? Do the parents need, you know, help with getting reconnected to education or employment? It's that sort of let's coordinate, which very often is the biggest barrier. And it's at a time when you got a newborn baby, nobody's got any extra energy to get those needs start to be met.
Right, and that couples with one of Illinois' great legislation around Medicaid. We actually now have up to 1 year full postpartum coverage. That is unique in the United States of America, go figure, because we know that about half of all maternal mortality actually happens in that 1 year postpartum. And that's really critical because the gap in maternal mortality between Black and white mothers in our country is almost 3 to 4-fold. And the most recent data that were released by the CDC in February of this year actually show Latinos' maternal mortality rate at an all-time high. And it's actually losing a lot of ground. And that's a really scary thing. So this program, in addition to the 1 year postpartum Medicaid extension, is really important.
Yeah, so the nurse makes sure baby's getting the follow-up connections, mom is getting the follow-up, you know, healthcare, which is critical, but it is also about all those other needs. And then at the community level with these community alignment boards, really building up the resources that are needed in a hyperlocal way.
Thanks, Doctor. Mauricio Peña, Chacuit.
Hello, Mayor. I had a question about vaccine uptake specifically in Chicago public schools. We've been analyzing the data since December on Chicago public schools, and we're seeing uptake is very slow in Black communities. We saw that at Black elementary and high schools, they had averaged about 22% fully vaccinated compared to 47% of Latino elementary, predominantly Latino elementary and high schools. Aside from these vaccine efforts and the clinics, what else is being done to reach these communities on the south and west sides?
I mean, you name it. I mean, honestly, this is a particular personal concern and frustration of mine. We have literally tried everything, from big public clinics, putting clinics in localized levels, working with the faith community, providing financial incentives, going literally door to door, vaccines at home, You name it, we have tried it. I've talked to fellow mayors across the country that have similar challenges with vaccines in African American communities. No one has figured out the secret sauce, in part because, you know, the question that I asked before, how do you overcome the fear? What do you do? And the only answer is a trusted community partner. We have done a lot of social media around people who themselves were vaccine hesitant, but then decided that they were going to get the vaccine, and then really using those testimonials, hoping that we can reach someone else who says, okay, I get it, I'm just like that person. But literally, we have tried absolutely everything that we can think of. What's worked in other neighborhoods? What are the pain points? I mean, Dr. Hardy and her team are doing deep research and surveys about what is keeping you from that, from getting the vaccine. This is a huge priority for us, and we've just got to keep at it. And part of it is publicizing and being very transparent about the data and where we're seeing progress. Also, not shaming people. I mean, that I think is really important, but encouraging progress, highlighting the progress that's been made. I mean, when we really started at this, I'll say last summer, last fall, we were seeing neighborhoods that were barely at 20%. We're significantly better now than we were, but nowhere near where we feel like we need to be.
Yeah, I would just add that the biggest predictor of whether a child is vaccinated, of course, is whether their parents or guardians are.
Yep.
Young Black Chicagoans, like young adult Black Chicagoans, are the least likely to be vaccinated in the city, and so therefore their children often tend to be. But I will say that on the, some of the outreach, we continue to do. We're averaging more than 3,000 vaccinations, COVID vaccinations a day across the city, which I do want people to hear. And for the last more than a month, Black Chicagoans have been the most likely to be getting first doses and second doses of vaccine. So this is not just boosters and whatnot. This is people making that decision at this point. And it is thanks to partners, like Phalanx and everybody. We have not stopped. We have not pulled back. We've kept those resources in. And wherever we see the uptake, that's where we put more resources sort of into that. I think we'll see what the vaccine cycle holds. If we end up needing to do something in the fall that's a little more universal, of course, we'll sort of take some lessons learned and go from there. But it is not all about vaccine, and that's really what this conversation today is supposed to, I think, help people think about some more.
A follow-up, looking at the data that we have and seeing that there are at least from December to the end of March, we saw that even still that I think nearly 75% of the schools had less than 50% of students vaccinated. Has there been any discussion about a vaccine mandate in the fall, and what does that look like?
Yeah.
Go ahead.
You want me to start? Sorry. No, I was just going to say that, Chicago kids actually are much more vaccinated than the national average in kids, so I do think that is important context. Overall. Yeah. But I think we'll see. At this point, we're still waiting for vaccines to have that full authorization. I don't see any world where there would be a mandate until there was full authorization, sort of at a minimum. And so waiting for that to get finished, I think more of the focus is on the vaccine being available for the very youngest children, which I do think is likely to be this summer. But it's in the conversation, but I think without a fully approved vaccine, it's a theoretical at this moment.
All right, moving on to Kristen from WBZ.
Hi, thanks so much for having this conversation. So much about what you all are talking about is access, right? Access to healthcare. And I was wondering, hospitals don't take all insurances. You can't force hospitals to take all patients. So I'm just wondering your thoughts on reducing barriers to access when we talk about making sure that every person has access to healthcare. And I realize people can go to Fqhcs.
Well, that's why the Fqhcs are so important. Because the emphasis on making sure that really there are no barriers to entry, regardless of ability to pay, regardless of insurance, regardless of citizenship status. The Fqhcs are a critical component of our future going forward for the very reason that you say. And they've done, tremendous work. I mean, we could give you example after example of how they have stepped up and done a yeoman's job, and they are, frankly, I think, less intimidating. They hire from the local communities, so when you walk in the door, you're going to see your neighbor, and it makes an enormous difference. And we will continue to lean, I think, very, very heavily on the Fqhcs for the very reasons that you point out.
Right, I guess what I'm thinking of is access to specialists in particular. Like when you bring up asthma, for example, it's not easy for a lot of patients who go to Fqhcs to be able to get access to specialists. There's also just, there's so many people going to Fqhcs that their resources are strapped. So I just wanted to bring up that larger piece of this to, just thoughts on reducing those barriers.
Well, I have my thoughts about it, but I'm going to let the actual professionals.
I'd love your
jump
thoughts
in.
too.
So, I will jump in and say part of the Southside Healthy Community, the Healthy Transformation Project, is about adding 50 specialists on the South Side. Right now, the specialists on the South Side are mostly at the University of Chicago. And most of you know this, the University of Chicago is at 99% capacity every day. And it's one hospital that just can't take care of the 900,000 folks on the South Side of Chicago. So this project is intended to take specialists and put them at the safety net hospitals. FQs don't typically have specialists. They have OBGYNs, and they're not always considered as specialists. They sometimes are considered as primary care, right? Exactly. But rarely do they house specialists within their site. We will put specialists at the site of FQACs on the South Side of Chicago, but mostly at the safety net hospitals where there are already ambulatory care practices, so that as FQACs need to refer their patients to any of our hospitals, whether it's UChicago Medicine, where there's not a lot of capacity, but where there will be capacity at the FQAC sites. That's part of our access, part of the access issues that we're gonna be solving. Also primary care. The Southside has 150 fewer primary care providers than it needs. It has 75 fewer specialists than it needs. And so part of our transformation project is to close the gap in access to those particular providers. Primary care at FQACs and specialists primarily at safety net hospitals on the South Side.
And when we look at the data, behavioral health is especially a place where people have trouble finding some of that more specialized care, and that's especially true on the South Sides. And so it's why we have, used a lot of additional funding in this administration to expand. We call this the trauma-informed centers of care, where we have been funding the placement of behavioral health specialists in federally qualified health centers, in community behavioral health centers, even in some non-traditional spaces, food pantries, et cetera. And that can be anything. Sometimes it's a social worker, sometimes it's a child psychiatrist, depending what the needs are. But we feel that using some of the existing trusted infrastructure and then plugging in additional mental health resources and some of that specialty care, as you say, is one of the most important ways so that everybody is able to access high quality behavioral health care as well. And we've seen a huge, we've gone from, we've had 7 times the investment in funding, compared to 2019 in mental health care. And we've gone from those funds serving about 3,500 patients a year. We're on track to serve over 50,000 patients this year, right? That's pretty amazing when you think about that amount of time, how many more people have been able to access. And every one of those has to take people regardless of their insurance, immigration status, or ability to pay. So we're trying to be creative in plugging some of those bigger need areas into existing networks and building that strength and that trust.
Yeah, real quick, Northwestern Medicine building in Bronzeville area is a really critical space that needed more specialty care, and so we're doing that over the next several years. But there is a structure that was in place that Brenda mentioned a few minutes ago. The mayor was innovative and progressive in creating the Racial Equity Rapid Response Group, the providers group, and we were part of the executive committee along with David Ansel at Rush and the major leaders providers across all the community hospitals and the FQHC networks, Access Alliance, Esperanza, Alivio, all of those. And we were meeting pretty much every 2 weeks for 2 years. And I want us to continue that, because what that does is it keeps each other accountable, it keeps the flow of information available, and we partner more when you have that structure. And also, we were banding around creating a health equity dashboard, which I hope, yes, we have, and I hope that we start to operationalize it soon, because that will help promote the specialty care and other access issues.
Actually, it is operationalized. IHA has taken ownership of it. Illinois Hospital, Health and Hospital Association. They've taken on, and 135 hospitals across Illinois have actually submitted their progress report. So we're in the second iteration of it, including Northwestern.
There we go. That's good to know.
Thank you so much to our speakers. Thank you very much, Mayor. Have a great day, everyone.
Thank you.